All right. Well, welcome everybody to EMS Office Hours. I am Jim Hoffman.
I'm Josh Knapp.
And I'm Dave Brenner.
All right. Well, we have the three of us here today.
The Musketeers.
It's pretty exciting.
Yuck.
I'm pretty exciting. It's pretty nice. Pretty nice. So, yeah. So,
hey, I missed you guys, and you just, go on without me. I fall a little bit behind, and you just like, he's not walking, kick him a couple of times and keep on moving.
This is how we learn.
I see.
Get out of bed and come to some of the earlier morning episodes.
It's you have to understand both biorhythms and the way the rest of the world works. Some of us were more to the late night hours. I'd be happy to do this podcast at 11 p.m. at night, but I have a feeling it's past somebody's bedtime here.
I can do 11 o'clock at night. I can do any time.
I can do 11.
Yeah, you can do 11? Yeah, well, then we should
I've been known to stay up that late.
Wandering the halls, wondering where the bathroom is.
I just take 2 doses of Geritol.
That's all. That's all.
The other option is, Dave, is to sleep till noon. And then, it's like everybody's gotten all this work done. You go, okay, guys, looks good. You're holding it together. Then you can go on and take a nap.
All right. Well, first of all, of course, anyone watching live, I appreciate it. Be sure to hit the like button below. Let us know you're watching so we know. I don't see everybody that's on here at the same time because this is going out to a couple of Facebook groups and YouTube, so I don't see everyone at the same time because Facebook has a thing with the groups where you can't see the peoples. So anyway,
where are our peoples?
I know. So what I wanted to do
probably sleeping
is I started seeing some things about patient assessment and wanting to maybe get your guys' tips on assessing some of the more I should say trickier patients, difficult patients, where it's you don't necessarily train on this in EMT school or paramedic school. Things like the psychiatric patient, assessing that type of a patient, assessing a patient that's in custody, with PD, they have them in handcuffs or whatever, assessing and treating and transporting these patients so it's safe for you and everybody else, and also that you can actually do the assessment and not get to the hospital and hear some, we found this, or the blood pressure is this, or the heart rate is this. And you're standing there like, well, he was in custody. I couldn't get to his wrist. I couldn't get to, different parts of his body or whatever the case may be. Or he was, the psychiatric patients where you don't want to agitate them and you don't want to get too close sometimes because you're afraid they might lash out or something. So what do you guys think? Like, do you have a specific approach to those types of patients, or do you limit your interaction because of that situation, or do you do sort of a vector type thing where, a lot of the times the patients that are in custody, they're calling not necessarily because they're really having a true emergency, but because they don't want to go to the hospital. They'd rather go to jail. They'd rather go to the hospital first for a little bit. So what are your guys' take on that? How do you approach that type of stuff?
Dave, I mean, look, I have a few years in the city system here, so I've been called to holding cells and jail cells a lot. The tombs downtown are a special kind of place. When your drug bag is bigger than the walls hallways that you're walking through, and it brushes both sides of the hallways. You understand that our sort of our penal system goes back a long, long way. with that said, there's a couple of different ways to answer that. You bring somebody in and the nurse says, oh, this, and this. And you're sitting there and saying, well, the person was cuffed. They weren't cooperative. I couldn't do anything. And I'm thinking, you didn't even try visual vitals, which are, we've discussed that on the show. That's certainly not the right way to go. But I have to tell you,
something you can do visually, I think.
You're not talking about vital vision. You're talking
Vital
about like a
vision.
respiratory rate you should be able to get.
That's exactly right.
Skin color.
Yep. Yeah.
Stuff like that.
Skin signs tell all. Somebody looks like they're crappy. They're diaphoretic. Their skin is pale. I mean, they look ashen. Something's going on, right?
I want to say something. The back of the ambulance is not the same place as an emergency room. And there are times that we have to take care of our own safety, and that the assessment of a violent and agitated patient, that we're doing our best to manage them safely without hurting them, is going to take the priority. If you don't come in with a full set of vital signs, an SpO2, an end-tidal CO2, a temperature, a BGL on everybody, I think there are certain circumstances where that's okay. I would hope, and we're a little spoiled, Josh, we're spoiled in the sense that we don't have a long way to go when you pick them up in general. I had an eye-opening experience when I was presenting in Kansas this August, and I was pretty much, I think I was talking about sepsis, but whatever I was talking about, somebody asked a question, and I said, well, they say people don't want to go to the hospital because it's such a, then they got to get home on their own. And I said, well, they can just call Uber. And I was told I was naive. They don't have Uber in Kansas. And sometimes the patients are being transported, over 100 miles to get to the hospital.
Yeah.
Right.
And so if we have 100-mile transport, I would go out of my way to make sure that when I'm picking up such a patient,
I'm sorry, Dave. You inspired me to a slight tangent, and I don't want to go completely off the subject.
Squirrel.
No. This is because I was thinking the gift that you have is that you get to go around to these other cities. You lecture, you integrate with EMS, you find out what their situations are. You understand that it's not a 5-minute trip to the hospital. It's an hour-and-a-half trip to the hospital. And in that period of time, it's like where a New York City medic who picks the guy up outside the emergency room and has to just drive around the hospital to bring him back to the emergency room, they have a greater transport. And more things can be done, but more things can happen.
It's a different practice of medicine.
Completely. Yeah. And what I wanted to encourage our viewers is, if you've never gotten out of your home state, if you've never got out of your locale, go to an EMS conference. I mean, that's a freebie. It's not free, sir, but it is a great way to get out. You can meet Dave. You can meet. Well, I was going to say Jim, but he's sort of sedentary now. He's, but if you get around to Florida, and I'm as guilty as Jim, I really don't get out that much either anymore. But, the idea is that you get to see how others are doing. And what's even better than that, take an advanced course somewhere else where you're integrating, where you're looking to use new tools, you're looking to use new processes, but you have to now learn that in Kansas City, they don't have the same setup that you have in wherever you are. Up to date
in Kansas City.
Right.
They've gone just about as far as they can go. Anyway, where I was going was that incarcerated, the patients in custody, for agitated patients. I'm going to tell you that the principles of psychological intervention, not what they tried to teach me in an EMT class with that 5-minute lecture, but the foundations of the psychological trauma in EMS patients, the PTEP class, the National Association of EMTs has put out in 2017, now an international course. And a shameless mention that I am one of the authors, one of the 6 primary authors, and I am student number 1 of the course.
And a damn good one too.
And it's an amazing course, and it works well with people that are if you think that being in a motor vehicle crash causes psychological trauma to a patient, and it does, being under arrest, in custody, handcuffed, that causes a psychological trauma as well. And that to the degree possible, I employ the same support that I would provide to any other medical or trauma patient. And I'm going to mention it, just the simple foundations. I provide social support. I let them know, no matter how agitated they are, no matter what they were arrested for, that when they're in my care, I'm there to help them. And I'm going to provide the very best care I can with the limitations of what we have. And sometimes the limitation is the patient. So I'm going to provide social support to the degree that I can, especially to a person who's under somebody else's custody or agitated. I'm going to give them the opportunity to make choices to the degree that I can. They're not going to get the choice if they're under arrest that, yep, can you pull over here? I'm getting out. That's not their choice.
Yeah.
But I'm going to give them choices, and I'm going to give them as much control of the medical exam that is prudent for me to do. Now, I know they lose a certain amount of control when they're in somebody else's custody. I know that. And I'm not going to offer them things that I can't deliver on. But, if I say, listen, I'd like to take a blood pressure, would you prefer that I use your left arm or your right arm? What's the harm in that?
Well, I find it's funny you said it, Dick. One thing that I have found is that when you have somebody, especially the psychiatric patients that are kind of a little bit on the edge, or the people who are under arrest, if I explain everything that I'm doing, ask permission for everything that I'm doing, and give them, even though, like you said, left
that's a
arm,
choice.
right arm, right?
When you say to them,
when you give them a choice, left arm or right arm for their blood pressure, it doesn't matter. It's a bullshit choice, but to them, it's like you're giving them some sort of control in that situation,
and they need it.
Yeah, and I think that lends them to look at you. Okay, this guy's not a cop. He's really an EMT or a paramedic. He doesn't really care about me going to jail or whatever. And like you said, it leans towards the fact that they kind of realize, all right, he's here to help me. Even if I'm full of shit and I'm making believe I can't breathe, or I'm making believe I have chest pain, this guy is still taking me seriously. He's still going to do what he.
You don't have to be under arrest to fake chest pain.
Well, that's true too. But but you get. You've seen videos. I'm sure we've talked about this. I think in the past we had videos of EMTs that went into a jail cell. They kind of blew the patient off, and the patient ended up having a
DKA
brain aneurysm or something, right, or something like that going on. And you see the video of them kind of ignoring the patient, not really attending to the patient. And, you can say, that's kind of an attitude you can take. But at some point, you need to do the assessment and address the patient, no matter what the complaint is, whether or not you feel it's valid or not valid.
So I want to remind our viewers that every time that Jim or Dave or I say that we've discussed this before, that there is an entire treasure trove of previous podcasts that we have done, And Jim and I and Dave have been doing this now for a whole bunch of years, and Jim and I go back even further than that. And there's some nuggets to be learned back there. But most important, if you're watching now, go to the Apple's iTunes and like us. Go to your podcast and like us. And that's how
Amazon. We're on Amazon now. We're on
right.
Spotify. We're on iTunes. And I mean, I go back as far as 2005 when I first started doing these things. And my very first one was when I interviewed Dr. Bledsoe back in the day.
It's one to listen to. Absolutely.
Yeah, so, it's funny you said, just to kind of go off on the side real quick. He actually did some kind of a he did a post, something like that on Facebook, talking about his life in EMS, and it's like his opinion and what he sees EMS being is almost exactly the same as it was in 2005, including the way EMS is still trying to evolve.
15 years ago, right? But I do want to just get back to the whole idea that what?
Wait a minute.
Sorry,
I
Dave.
was in the middle of telling you the things I would do. I got two more. I said I would provide. I got to finish it. Social support.
Okay, sorry.
Introducing myself, and I use this line, and it sounds corny, and people tell me they can't use it. Just don't use my name. But the line works, and watch what happens to your patient when you say, don't say Dave Brenner. Hi, my name is Dave Brenner. I'm a paramedic. I'm going to take really good care of you, not good care of you, or I'm going to take care of you today, or I'm your EMT today, like you're the person serving them in a restaurant. But I'm going to take really good care of you. Social support. You give them choices and control to the degree that you can. One of the things many people hate, I know I do, is not knowing what's going to happen next. So you let them know what's going to happen next. We can anticipate. They want to anticipate. How long will it take to get to the hospital? What will happen when I get there? You know what's going to happen. They're going to meet a triage nurse. The triage nurse is going to ask them all of the questions we already asked them. Right. But tell them that this is what's going to, and then the triage nurse is going to decide where in the emergency room they're going to get treatment. All right.
So isn't that sort of an important thing that we do within EMS is build that communication bridge,
or fail to build it,
yes, but our goal is to build that,
and it would be great if we were all trained specifically to address all three of them I've already mentioned. All right. It's like, I know every time I mention something, there's a squirrel. That's my job.
Right. We want
my job. So even if you're going to lean them back and you say to them, they're sitting on the stretcher and you're going to lean them back, say, hey, we're going to lean you back. Hey, when we get to the hospital, we're going to take you out and we're going to go with you. Yes, the police officer is going to come with us if that's something to be anticipated. Let them know everything that's going to happen. This is not only good for them, it is a management technique that allows them to put their faith in you. They know what's going to happen. And then the final thing is, to the degree possible, because Jim, you grouped them together. You said people under arrest, people with psychiatric or agitated disorders. Let them get involved in the planning process as much as they can.
Yeah.
Is there anything you would like to do before we leave the house? Is there anything we need to do before we leave your car? And maybe they've been arrested for DWI or whatever. Is there anything we need? Okay. And really, I like to give people choices, and it's part of the planning process as well. And I know we discussed this at another time. I would give people choices of which hospital to go to a degree. I mean, I'm way out in the middle of Suffolk County. I had a woman giving birth at 2:00 in the morning who told me to take her to St. Luke's. And you could have read the ha over my head. By the way, she gave birth on Nichols Road. She named the child Nicole because it was on Nichols Road. I told her she could have had little Horace Harding or Kosciuszko if I had followed her advice, which would have been fine. But so let them anticipate what's going to happen, so there are no surprises, even how long it's going to take. And the final thing, I said before, is let them get involved in the planning and the organization. if they can. Their brain needs to do this. It helps their brain settle down when they start making decisions that make sense, when they become part of the organization rather than simply have things that happen to them. So, in summary, social support, choices control, anticipation, and planning an organization. If you do that stuff systematically, if you plan it and you do it throughout your call, it calms the patients down.
And that was straight out of Dave's paramedic lecture. So you can email Jim for the
No, but you know what?
CME.
It's David makes a good point. I think that all
It's
of it
an
is very
excellent
important. I mean, you should be doing that with all your patients, but I think
You're right.
But I think that when you encounter some of the more difficult patients, doing that and being more conscious, I think, of doing it is more important. A lot of times when you have a regular patient, you might say, "Oh, I want to take your blood pressure," and then you just take. It doesn't matter what arm you're doing it in. You know what I mean? Or you might say, "Check your pulse," or you might say whatever, and you're kind of just going through it, and you're not really that concerned about of the 80-year-old female lashing out at you as you would be the 20-year-old male that's in handcuffs. You know what I mean? So your approach is a little bit different, even though you should be explaining everything to them and introducing yourself. I mean, Dave, you mentioned about giving them good care. That was a place that I worked where they insisted that every time you made a patient encounter, it was, "Hi, my name is Jim, and I'm going to provide you excellent care." They wanted you to say that for every patient, and they drilled it into you when you got hired. They drilled it into you when you were doing your FTO time and all that type of stuff. And yeah, it's kind of corny. It's kind of, I don't know, a little stilted. But when you say that, like you said, Dave, it starts the communication between you and the patient, much
calming.
better. Yes.
So much of these are the mirror of presentation skills. If you have to give a lecture in front of an audience, if you have to teach a class, these are the things that you want to come in and communicate. "Hi, I'm so-and-so. This is, I'm a subject matter expert in these things. We're going to have fun today." You can sort of, switch those out to, "I'm going to take real good care of you today." Those are the things that are excellent in building the bridge. I want to throw in a note of caution that sometimes when you're doing this, you can be very effective, but your read on what's actually going on, or you don't know what's going on in your patient's head, and that is not an excuse at that moment for you to drop your guard, for you to be unaware of the other aspects that are going on. Situational awareness is a key aspect of building that bridge with your patient, but also keeping yourself safe.
Sure.
Yeah. Definitely. Definitely.
There.
What's that?
Nothing. Go ahead.
There is some guidelines, and I was looking it up. I'm trying to find they actually had a protocol that they wanted you to follow for every patient, and I thought that I'm not going to do it now because it's kind of extensive, but I think I might do a video on this to kind of give it to the masses as sort of a way to that initial approach to patient. And they actually developed it off of a paramedic that was worked there, that was very into the patient experience and providing excellent care. And they developed this whole protocol on your approach to the patient, their surroundings, their situation, the assessment. And it's just one page, but if you look at it, it really does talk a lot about what you talked about, Dave. So I just wanted to just kind of talk about that today a little bit, guys, because I've been seeing a little bit about that in some of the Facebook groups, on people that are new and they're thinking, "Oh my God, when I in EMT school, there's just a mannequin laying there, or my my fellow student, and I'm doing the head to toe, and no one's thrashing about, and nobody's got their hands pinned behind their back, and and they start encountering real patients in the field. And like you said, Josh, if you're in a place like New York where you get a lot of these encounters pretty frequently, you're thrown into it and you're like, what the hell's going on? I'm suddenly having these patients on a regular basis, and you're not quite sure what to do. I remember when I first started encountering these types of patients as a new EMT in New York. It was an eye opener. It was you're taking a step back. I go, wait a second, I'm not just doing these little old ladies and trauma on the highway. I got to deal with criminals and psychiatric patients that might hurt me. So with that, I wanted to talk a little bit about something else before we end the show.
Nice segue.
That was smooth, actually. I'm actually interested in what you have to say.
Right. I want to talk a little bit about the situational awareness that we need to have. And the reason, I know we've talked about it before, and I think several times with a lot of other guests that we've had on shows and stuff in the past. But things that we need to just, I mean, listen, this might be very basic for a lot of people, but nowadays you're seeing more and more attacks on EMS providers. You're seeing more, I mean, just recently that somebody pulled a gun out on 2 EMTs in New York.
There was a active shooter in the Bronx.
There was a firefighter that was shot and killed, just a few days ago. And I think it's becoming more important than ever to have that situational awareness. But with that, one thing, and I watched a video from a EMS paramedic, and I'm going to try to get him on the show. But he talks about something that I've been big about for many years, and that is EMTs and paramedics that feel as if the uniform and sometimes the badge that sometimes you wear, and depending on where you work, gives you some sort of perceived authority that you think you are equal to a police officer, and you start acting that way, and then in turn sometimes might get treated that way, and meaning somebody trying to beat the shit out of you because you're mouthing off, you're being too arrogant, being too nasty to people because you think that you've got some kind of authority. Listen to me, get on the stretcher, get on this, go here, do that. I'm in charge, not you. I mean, there's a place for that.
You're going to the hospital.
Right.
I've heard that so many times.
There are some situations where you have to be more very matter of fact about things. But this is something I would have fights with partners about, saying, dude, don't ever pull that again on a call, because you do not have a gun. I don't have a gun. We're not cops, and whatever perceived authority you have, you don't have, because many times it's just you and your partner on a call, and if things go sideways, it's going to take a while before you get somebody there to help you. I've been in that situation many times where, I'm calling for assistance, and it seems like forever before that assistance gets there.
Well, if you have to call for assistance because none was coming, it's already too late.
Yeah, that's the problem, right? I mean, I was in situations where you think there's no worry for anything, and then next thing you know, somebody's pulling out a knife on you, or threatening to get a gun or whatever. So I think that the situational awareness thing is very important, and something that I would encourage is that the scene safety element of our approach to calls doesn't end when we first get on scene. It's something that we need to be doing repeatedly through the call. I don't know if either one of you have ever had the situation where you're in a home and you think it's just you and the patient and maybe another family member, and you're talking and you're going about your business. Oh, somebody comes out of a back bedroom, and
with a 100-pound dog.
Yeah, well, exactly. Or even a dog gets out of some place, and where does the dog come from? and that's all part of it. And I don't know if you guys have any quick tips for people for that, or experience you want to kind of convey that might open eyes to that possibility. But I do think, like I said, I feel that now you're seeing more and more of this. I don't know if it's because of the social media and everybody has videos and cameras, and more of it's getting videotaped and more
I
of it's
think
getting
that's a part of it.
or if it actually is becoming more prevalent because of just a climate of people not having respect anymore for any type of authority.
So I do have a few thoughts on that, and number one is
Right, Dave.
the
I didn't
number
say
one
anything.
is what is taught, what should be taught or is taught in every EMT and paramedic class that you ever take. And that is, your number one job is to go home safely at the end of the day. And everything else grows out of that. And when you start to talk about, perception and what your perception is of yourself versus what you actually are, what your role in this scenario actually is, you sometimes, even though the excitement is kicked up and there is a level of authority coming in as an outside entity tasked with public safety, yours is not the role of the police. And especially with the last thing that Dave and Jim said was, with cameras, you especially there's smaller, less and less gray area that you can get involved in this and come out unscathed. So you really need to keep that internal focus of what is your job, why are you being called, how do you act appropriately, and you are not law enforcement. That doesn't mean you can't take on a self-defensive role, but you're not there to facilitate an arrest, for instance, or to mitigate somebody who is a danger to themselves and others. You're there for the health and transport of that individual to more defined care. That's what I really wanted to throw out there. I'm very big on situational awareness, but coming with situational awareness is your mental attitude of what your role is. And
Yes.
I think that's extremely important.
Yeah, I will say that I think that one key thing as well is presenting yourself as a professional, right? If you present yourself as a professional, and it kind of goes full circle back to what we had talked about in the first part of this, is explaining to the patient everything, asking them permission, giving them choices that are appropriate for their care and transport. And then that is going to establish you as a professional, as somebody who is in charge of the situation, right? And that is going to lend it so that you don't need to be the person that is more aggressive, or more, like Dave said, get in the ambulance, you're going to the hospital type thing. If you present yourself with, the way your uniform looks, the way that you act, the way that you speak to the patient and family and whatnot, that is going to go a long way to preventing further issues. Now, there are patients and family members that no matter what you do, will get violent. You know what I mean? And you end up in that situation. But anyone that thinks that, oh, it's not going to happen to me, or I can handle it if a patient, loses it, it's me and my partner, it's 2-on-1. So I don't know if anyone's ever seen some of these videos of two police officers wrestling one person, or even more than that, wrestling one person. It can be, the
You've
two
already
people
lost.
lose.
You've already lost if you have to wrestle.
Yeah,
Right.
I've been in a situation. There's been 5 or 6 of us trying to restrain one person, and it's nearly impossible. Just you're trying to use restraints, on their arms and legs and stuff to restrain them to the stretcher. and you've got
Right.
5-6 people trying to do it. So don't think that you in somebody's home or in the back of an ambulance that someone starts to freak out, that you're going to somehow subdue them easily. We're not all trained in jujitsu and stuff to start, taking patients down with your thumb.
But even if you can overpower them, and even if you can easily overpower them, and stop their forward moving efforts, they could continue to resist you and fight against you, and all of your good efforts are going to go away when they get into the ER. They find they've got rhabdo, their kidneys are destroyed because you restrained them.
Yeah,
and even
that's another issue you have to think about.
And you don't want to be in that position at all. I mean, I've seen that happen with just people having seizures. There's no intent. Nobody gets angry at them, but they're being held back, and they have this literally uncontrollable urge to exert. And if we don't manage that correctly, they're going to damage themselves. And we were there to stop them from damaging themselves. So,
yeah,
we got to get better at that. And we got to get better at,
and there are classes out there people can take. There's videos to watch that people can watch on all of this type of stuff. There was a presentation that was done, the Art of Patient Rapport, that goes over how to speak to patients and how to build the rapport when you first encounter them. So going forward, if something goes wrong or they take it the wrong way, it's not as detrimental to you or them if what's going on doesn't work out. That the full assessment. If they get violent and they end up getting restrained, you've done everything. You can say to yourself, I've done everything that I could to avoid the situation. Like Dave said, if it's at a point where you're wrestling, it's too late for any of that. So start out with I'm going to give you excellent care. Can I use your left arm for blood pressure? What hospital would you prefer to go to? All that type of stuff. Instead of you're going to the hospital, there was a cop once that was on the scene with us with a psychiatric patient, and he tells the patient, I'm going to ask you to go, then I'm going to tell you to go, and then I'm going to make you go.
I said that
patient didn't like that. He chose make me go. So we ended up, you know what I mean? Some people are like, screw you, man. I'm gonna roll the dice. Go ahead, try to make me go.
As an excellent point of a reoccurring theme of this podcast is for our listeners to use the resources out there to improve your skills within EMS. And there's a ton of resources out there, because experience is a great teacher, but it is an unforgiving one. And sometimes that lack of experience can,
you have to survive the experience.
Exactly. And your career or worse. And just talking about these type of things, it is when you come into a combative situation, there are so many variables on this about the scene. There is no way that just winging it is going to get you through. I mean, luck might, but winging it won't.
Yeah. Listen, we've all been new, and when I was new, I winged a lot of stuff. But I've learned.
Make it till you make it.
I learned from it, and honestly, and this is something I tell people a lot, when they inside TurboMedic and on the Facebook pages and stuff like that, is, there comes a time when you have to sort of self-educate yourself on things, because you're not going to get a CME on everything you need to know to be a good, EMS provider. You're not going to get it all in your initial classes and stuff like that, or you might get a small segment of it. So go out there and find the resources, like Josh said, to be better at EMS and to be better and be a better EMS professional, because of the fact you're taking time to invest in yourself, which in turn is going to relate to what you're doing out there, with your partner and with patients and doctors and nurses. It'll come across that you're doing more than just the basics and you're not winging it. The end. All right, so guys, we'll wrap it up there. We've been going for about 40 minutes. I do appreciate the few people that did jump in today that we saw. Thank you so much for liking the show. And like I said, be sure to go to Spotify and iTunes and Amazon, and you will find the show there. I'm sure one of those could be your favorite platform where you can like and follow the show. And listen to all the previous episodes as well, and upcoming, and get notified when new episodes are posted. So anything else you guys want to talk about? Any last minute thoughts on today's subjects?
No, I thought they were good. Good subjects worth talking about.
Yeah.
Always worth talking about.
I have another one that I want to talk about, but it's not, we don't have time for today, but next time I'm going to bring it up.
Well,
kind of goes along the same lines of what we're talking about today. And I thought about it. I've been meaning to bring it up and want to discuss it, but
write it down.
I have to write it down.
Jim, the redness should go away.
I'm very big on making lists lately. Been very big on making lists lately. I've been Mr. List.
Okay.
All right, everybody. Thanks again for joining us. As always, I am Jim Hoffman.
Josh Knapp.
Dave Brenner.
Stay safe, everybody.